Thank you very much, Dr. Dandis, Dr. Pai, Dr. ISWHR. I already took 30 seconds of my talk walking up here, so I'll hurry up. Thank you very much for the opportunity to be here. This is an incredible meeting, both scientifically as well as culturally, and it's an honor and privilege to be here. So I'm just going to talk briefly about ACOG's, some of ACOG's work relative to maternal morbidity and mortality, talk a little bit about the mortality rates and the problem. We know this is a worldwide problem, and then address just a couple of the programs that ACOG is doing to try to address this significant problem. So we know maternal mortality, again, is a significant problem worldwide, and unfortunately the U.S. has some pretty high bars on this graph, and it is, the rates are terrible. I think we could all say that one maternal death is too many, but the U.S. certainly faces high maternal mortality, and the other fact shown on this slide is there are also disparities in outcomes with several populations, including the Black and Hispanic population, facing much higher mortality rates than white women. We also know, and we've heard several times at this meeting and other talks, that COVID also had a significant impact on maternal mortality, increasing the rates higher than we've ever seen. The Centers for Disease Control and Prevention tracks this data and noted the highest rates ever due to the significant increase in pregnancy-related deaths due to COVID. And you can see that we went from 15% in 2020 to 41% in 2021. The unfortunate thing is when I put these slides together, when I made the copy to bring, it didn't download the graph that was supposed to be here. But I wanted to keep the slide anyway because it points out, and we'll see this a little bit more later, that the disparity, so we really need to concentrate on both. The other important thing this slide points out is we were all trained that the typical postpartum period ends at 6 weeks. And we've been fighting very hard at ACOG to push postpartum considerations out to a year. And one of the reasons is because a significant proportion of maternal mortality occurs more than 6 weeks, and between 6 weeks and that first year. And when you look at the considerations particularly related to cardiovascular disease, that's the biggest offender, that most of these deaths actually occur in the postpartum period, particularly in the beyond 6 weeks postpartum, particularly when you look at cardiomyopathy. So it's really critical that we send the message that postpartum doesn't end at 6 weeks. You really need to think a year out, depending on the potential cause. I also looked at what is India's, and this is from data from a 2022 publication, and obviously the causes are similar to what we're seeing in the US, but little different percentages. And here you can see, at least based on this study, in India, hemorrhage is a leading cause of maternal mortality. And we've heard several talks at this meeting addressing hemorrhage. So the maternal mortality review committees, one of the things they do when they review these deaths is determine if they can be preventable. And it was determined that resources, the right equipment, and the right processes. And it's really important to verify that you really have what you think you have, because you think you have things, and then you go looking for them, and you realize you don't. So it's really critical that verification is involved. When we first launched this program, or the document, we got a lot of pushback, but the concept of levels in medical care is not new. Neonatal levels, intensive care units, trauma centers, acute care, and there's others. So the idea of levels of care in the maternal world shouldn't be new. So what are the levels? Probably not too surprising. Level 1 takes care of the least complicated patients, but if they do have complications, have the ability to detect and recognize and stabilize. Level 2 provides some degree of specialty care, taking care for slightly more complex patients. Level 3 includes subspecialty care and really takes care of probably the bulk of really complicated patients. And the level 4s are those highest level regional centers that have subspecialty care, a number of resources to take care of the patients with the most complex conditions and critically ill patients. One thing we were prompted on when we launched this is you need to tell us what conditions I can take care of at each level. When we did the 2019 revision, I literally went through an obstetric textbook, made the list of every complication there was, and I tried to pigeonhole those into different levels and realized this was a fruitless exercise because we can't tell an individual hospital what they can and what they can't take care of. They need to figure that out. They know what resources they have. They know what additional challenges are, geographic challenges, weather challenges, to be able to transport patients. But what we did do, though, is encourage facilities and regions to determine for themselves what they have the resources for, what they can take care of, and again, they can't overemphasize, recognize what they can't take care of, so they make sure they get that patient to the right place. Soon after we published the document, we thought, this is a great piece of paper, but we really need to do something with this. So we developed a verification program. The CDC already had a self-assessment, self-reporting program not designed necessarily for facilities to determine their level. So we decided to create a verification program. We partnered with a number of organizations, including the Perinatal Trust in Arizona, which had actually been doing a program like this for about 30 years at the time. It involves a site review with a report and feedback given to the hospital. We piloted in 14 hospitals across 3 states, including states with some significant rural and geographic challenges to transport, and we published a commentary several years ago summarizing the experience. While we were doing that in Texas, the Texas legislature passed a bill saying levels of care would be implemented. The Texas Department of State Health Services was given the responsibility of conducting this program, and ACOG is one of 2 organizations in Texas that was given permission by the State Health Department to conduct the verification program. And basically, ACOG went in, surveyed the hospitals, verified compliance with the requirements set in by the Texas law. And we launched that in 2018, and it's still going. While we were doing this, we thought, gee, wouldn't this be great if we could do this nationwide? And then we realized we'd need another building and about twice as many people to do that. That's just not ACOG's business. But the Joint Commission, who's an accreditation agency in the U.S. that accredits a significant number of hospitals across the country, reached out and asked if they'd be willing to partner with us. What we didn't have, the infrastructure to conduct these visits, they had. So we partnered with them, and basically the Joint Commission is conducting levels of care verification in all states except Texas currently, and that program launched in January of 2022 and has been very successful. Similarly to what we did in the pilot, it does involve an on-site survey. They ensure that the hospitals have the necessary facilities. It is a voluntary program, and the key point is education and support. This is not a penalizing visit. This is a supportive visit. They wanted to provide education and resources to help these facilities optimize their capabilities, again, to take care of these complicated patients. So I'm going to switch gears to a different problem, identifying and managing obstetric emergencies in non-obstetric settings. So we know that postpartum patients, particularly with complications, often show up not in our clinics, or they'll show up in the emergency department, an urgent care clinic, a primary care clinic, because they will have these problems, and they will show up in these other places to clinicians who don't have the familiarity and the knowledge and the experience to care for these patients because they just don't see them very often. So we held a meeting back in 2021 with a number of different organizations, recognizing that we need to increase the awareness of these non-obstetric clinicians about these problems so that they can recognize them and do whatever they can do to initially intervene, to stabilize, or treat, depending on the situation. They need to identify that patients are either pregnant or have been pregnant within the last 12 months. You're never going to think about postpartum cardiomyopathy if you don't know the patient was pregnant within the last 12 months. And the whole goal of this is enhance readiness of these groups to be able to care for these patients. So we focused on emergency departments, pre-hospital care, and then the urgent care centers. Some of the early conversations where there were that was that there were significant knowledge gaps. These clinicians didn't know about the physiology of pregnant and postpartum patients. They weren't aware of the risk of complications in the postpartum period, especially when you go beyond those first 6 weeks. Again, there was a lot of misperception that once you get beyond 6 weeks, you don't have to worry about it anymore, and that's clearly a message we needed to change. That they needed to understand the red flags and the signs and symptoms, particularly related to blood pressure. The current lead for our program for the EDs is actually an emergency department physician, and she joked that if I walked into the ED and my blood pressure didn't start with a 2, they would just kick me out. But it's key that they need to recognize that a postpartum patient with 160 or 110, that is a clear medical emergency. So they have to understand that patients are either pregnant or postpartum, and if that is, that needs to flip a switch, need to think differently on approaching this patient. And not surprisingly, practitioners are ill-equipped. They don't see these patients very often, they're not trained to recognize it, and there's a lot of fear of treating pregnant and breastfeeding patients. I'm sure we've experienced that when we deal with surgeons, anesthesia colleagues, etc. So with this, we developed a number of materials for the emergency department. We developed some algorithms, and the first ones we focused on were hypertension, eclampsia, and cardiovascular disease. We're developing EMS guidelines, including hemorrhage. Urgent care guidelines are in process. There's information materials, educational sheets. What we try to do is develop resources that these clinician groups were most used to. ED clinicians use a lot of algorithms, so we wanted to do an algorithm for them. The EMS uses more of a guideline approach, so we wanted to develop materials that they're used to seeing. So for the ED, and I know you can't see these, but these are the algorithms. So the left one is the hypertension algorithm, the middle is eclampsia, and the one on the right is cardiovascular conditions. These are available on the ACOG website if you would like to see them. These are already in the EDs. Our ED folks are using this. The other really important thing were patient-facing posters. The patients can be their own best advocate. If that clinician doesn't ask if you're pregnant or have been pregnant within the last year, then please tell them, again, because they need to flip the switch to recognize a different set of conditions and a different approach. For the EMS and the first responders, EMS is really important. They will see these patients as well, and identification is critical, particularly with some of the closure of OB units across the country and some of the rural settings. With longer transport times, they need to be able to stabilize these patients until they can get them to the facility that can further take care of them. So knowledge is really critical. These are the drafts of the guidelines, again, developed in the format that they're used to working with. So hypertension, eclampsia, and postpartum hemorrhage was a real focus for the EMS folks. Scary sound. The EMS informational sheet, they also asked for background information to support why we recommend what we do. So this informational sheet with bibliographies are provided to them as well, again, so that they understand why we approach things like using magnesium for seizures. They don't use magnesium for seizures in basically every other patient. And then urgent care, we're currently partnering with a number of other organizations developing these to develop similar to guidelines to what we're doing for the urgent care setting, as well as the algorithms. Finally, AIM has an obstetric readiness resource kit. This is a collection of best practices to aid in readiness resources. It complements the clinical information, and it's dedicated for those, again, who don't provide this type of care routinely. So in conclusion, maternal mortality is a global issue. We need to recognize mortality as the tip of the iceberg. Morbidity is far bigger of a problem, that there are significant disparities. We need to all collaborate and work together. And then finally, hopefully these two resources are just part of the answer to the problem. Again, I'd like to thank you very much. I think you say this, Dhanyavad. Very much appreciate your time. Thank you for the opportunity.
Thank you, Dr. Christopher Zahn. That was a very enlightening talk.